Thank you very much. And I'm going to talk about the pediatric retinal surgery. अरे इसको change करो यार इसको. हाँ, okay. So pediatric retinal detachments, they are about 3 to 6% of the total detachment. And out of pediatric retinal detachment, we have rhegmatogenous retinal detachment. We also have traction detachments. And we also have the exudative retinal detachments as far as the pediatric retinal detachments are concerned. And the main causes of retinal detachment in pediatric age group is trauma. Trauma is a sizable number of these children. They have the retinal detachment. We have next is the myopia. And then we have next is vitreoretinopathy. We also have retinopathy of prematurity. And of course, the coloboma related to retinal detachments. And basically, the pediatric retinal detachments, they occur under pediatric age group as per WHO definition. It should be less than 14 years, as although is mentioned, normally it happens in 9 to 12 years. Now, why are pediatric retinal detachment different? It is different because of the presentation. How does it present? Most of these detachments, especially up to the age of 2 years, it presents as a leukocoria, and then it presents also as a strabismus. And most of these detachments have PVR changes because they come late, very late. And I know about India and also maybe other countries as well. So since they come late, there is a PVR changes, more than 50% of these cases. There's involvement of the macula, and therefore the vision goes down very much. And there is a total detachment, again, because the presentation is late. And many of these cases have bilateral pathology, especially the inferior dialysis, which is there. It does happen in other eye also, although traumatic dialysis is also there, but that is one very important point for differentiation between the traumatic dialysis and the congenital dialysis, retinal detachment. And the bilaterality of pediatric detachments are almost 25%. I think it is more, it should be a little less. Then the intraoperative, the difference between the adult and the pediatric retinal detachment is the sclerotomy when you are passing, because the sclera is thin and possibility of having perforation is very high. It may also have the concomitant cataract, and the PVD induction is very difficult, and especially if you talk about the ROP and the detachments below the age of 2 years, there the vitreous is in sheets. You remove one sheet, the another sheet is there. And of course, the surgical maneuvering is little, you have to be careful. The reason is the eyeball is small. Although, up to by the age of 14 years, the eyeball becomes almost of the normal size. Another important thing is the instrument. And this is very true for ROP surgery, because the eye is small, and if you use the normal adult, equipments, especially the intravitreal instruments, then at times it becomes little difficult. I believe some companies are there who have made these pediatric intravitreal instruments. And then other important aspect is the management of PVR. Post-operative management includes the good positioning, because in children, many times it is difficult because they are very playful, and it depends upon the child. Some child are quiet and some child are very notorious, like Vaichi. So, so maybe he may not follow the order, and that may becomes another problem. And then the question of sensory deprivation, amblyopia is also there. Then what should be the goal of the surgery? The goal of the surgery should be clear the ocular media and relieve all the vitreoretinal traction. This is more true about the retinopathy of prematurity, because too much of aggressive surgery is, put you in the very difficult situation. Mostly, if you do too much, then there is a retinal break, and once there is a retinal break, the whole story is over. Scleral buckling should be done for the simple reason because there is a vitreous, and vitreous is very tough and it is adherent, and also because there is a phakic eye, and invariably if you do vitrectomy, the chances of cataract becomes higher. The positioning in vitrectomy is a little difficult because especially when you use gases or you put the silicone oil, and then if you do the scleral buckling, the risk of cataract is not there. And there is no need for removal of the silicone oil. And this is the picture, after this SOR injection is there. And if you want to plan for vitrectomy, you need to have two things very important. One is the appropriate lens management. And other thing is when you enter inside, do you want to enter, then the placement of the trocar is very important. Also, you should have a good, intraocular pressure when you are, entering inside. And for this, you have to have a good infusion, a kind of, the intraocular pressure should be of that kind. What are the do's for the when you are doing the retroretinal surgery in children? And this is the, where should we go put your trocar? And it depends on the age. Less than 6 months, normally we all do 1.5 millimeter, 6 to 1 year, 6 months to 1 year, 2 millimeter, 1 to 2 years, 2.5, 2 to 4, 3 millimeter, and more than 4, 3.5 millimeter. But this may little vary, depending upon the situation and depending upon the cases, but by and large, we follow this dictum. When you are, this is about, we have already talked about it, and then what are the don'ts? The appropriate lens management is very important. Don't forget if you have left the eye aphakic, you should do an endo PI, and this is very important because the pressure may go high, and you need to make a room for for the intraocular pressure, and so that in post-operative period there is no glaucoma. And when you are going inside with the trocar, you should put it obliquely. You shouldn't go horizontally, because if you do horizontally, then you will damage the retina. And when you are doing surgery, you should, ensure a good PVD. And there's a picture you can use, put this intravitreal tamsunolone, and you can start doing the PVD induction from the posterior pole, especially from the nasal side, so that you don't damage the macula. Lift, and then you can go around. Another thing is you should consider buckling also, because it ensures when you are doing buckling, you should not have the globe perforation. When you are passing suture, one has to, there is a rule called Jamaican rule. I don't think you have read. I read in the book, Jamaican rule is that when you are passing the suture and when the needle is there, the needle should, should be, visible. It should be visible underneath the sclera. The moment you see that it is gone, it's not in your vision, it means that it has gone deep and there is a perforation. And then, of course, as I told you earlier, no aggressive PVD induction should be there, because if you do that, there is a chances of bleeding is there, chances of iatrogenic break is there, and of course, and then you can use PFCL as a short-term tamponade, and for that you need to have a supine positioning. But the short-term tamponade means you have put the PFCL and you need to remove it the second time, and therefore the use of PFCL should be judicious, not that you inject in every eye, and that creates problem for you and also for the patient. And some people are using higher viscosity silicone oil as tamponade, and at times it does work. I have used, higher viscosity silicone oil, but I do not know, it doesn't make much difference in that. And so far I know it's not very much in use now. Earlier, at a time when it had come, then it had, made a big, noise. But later, when we realized that it doesn't work much. And then when you are pushing the silicone oil, there should not be underfill and there should not be overfill. Although it is very easy to say, but when you inject, so many times it becomes underfill. Nevertheless, if underfill is there in case where there is a superior tear or there is a superior cryo and other things you have done, then there is no problem. The problem arises when there is an inferior tear and there is a underfill, then the oil goes up and then the detachment starts coming from down. So that is another important thing. And then, this is the ROP, for ROP. If you want to decide about the surgery in the case of stage 5, these are the ultrasound picture, and you can see if the funnel, is anteriorly open and posteriorly closed, as is seen here in the first B-scan picture, then you can try your surgery. And if it is totally open, then you can more reasons to try. And if it is something like this, that anteriorly it is closed and posteriorly it is open, there's no point in doing surgery here. And of course, a third one where it is totally closed, just like a pipe, so it doesn't make any sense in doing the surgery. And this is what we did was we did UBM in these cases, and we wanted to see how much is the space in the pars plana. If the space is very small, the ciliary body will come in front, and when you are putting the trocar, then you may hit the retina because retina is very close. So you can use the UBM to assess the surgical space and decide about the lens sparing vitrectomy. And as we talked earlier, that removal of traction by the blunt scissor and not with the sharp scissors. And so you should try not to have retinal hole, because if hole is there, so much of traction is there, then the surgery will not be effective. And this is the pediatric retinal attachment should be congenital anomalies. And good core vitrectomy is needed, debulking and high suction and low cut rate. Cut rate should be smaller. And this is, with the coloboma of the choroid, retinal attachment with coloboma. And all of us now are using tricot for induction of the PVD. And after that, you can settle the retina and put the silicone oil. In these cases, the silicone oil has to be injected. So to conclude, the best possible preoperative assessment and surgical planning is needed when you are doing a pediatric retinal surgery. It is good if the patient comes to you early and you decide about an early surgery. Managing lens is a big issue, and it must be considered. And you can use the adjuvants, but judiciously you should use wherever it is needed. And most importantly is the counseling to the parents, because the children, they come with their parents with lot of hopes. They think that we have come to a very expert doctors, expert surgeons, and everything will be all right, and the child will get a good vision. Unfortunately, it doesn't happen. So a good counseling is the key to give comfort to the parents and also to yourself. And then the other eye should also be looked into, because the other eye is very important, and especially in cases of trauma, because one eye has had trauma, and after that the other eye should be preserved and should be taken care of. So I think that was the last slide. Thank you very much for this.
Yeah. Thank you very much, Professor Azad.